Hello, this is Dr. Patterson, and this lecture covers the respiratory system. I know a lot of the A&P is review, but I think the importance of the review is so that you can see the anatomic locations for listening to the heart and lungs in association with the intercostal spaces. Note the costovertebral angles. Also, when thinking about the locations that you will listen to, think about listening to all the lung fields. Note where the lungs start and where they end. For our assessment in lab, we will be listening to a specific number of locations. However, as I always say, every patient is unique. Some may have a longer torso and you may have to listen to more areas, while some may be smaller, where you would listen to less. In your nursing practice, many assessments will be based on your unique individual patient, but the main objective is to be thorough in your assessment. Listen to each inhale and exhale in its entirety and over the complete span of the lungs. These images are helpful in determining important landmarks. When listening to the lungs, you will want to avoid listening over bone or the scapula. We will perfect these techniques in lab. For review purposes, note the midclavicular line because we use this to locate our PMI, apical pulse, and hear the mitral valve in the same location, the fifth intercostal space, midclavicular line. These next two slides are helpful in viewing the lobes of the lungs, 3 on the right and 2 on the left to make room for the heart. This is a lateral view of the right and left lobes. The normal breathing pattern in an adult will be automatic, diaphragmatic, involving inspiration where the thorax expands and expiration where the thorax relaxes. Accessory muscle use is a term that you will hear frequently as a nurse. When someone is using their accessory muscles to breathe, think respiratory distress. You can assess this just by looking at the patient or on inspection. This is in reference to the muscles that are normally not used for breathing, such as the sternocleidomastoids, scalenes, and abdominal muscles. Although not covered in this course, keep in mind this variant with infants, where abdominal breathing is normal. If a patient has any of these acute symptoms, the history may be provided by a friend or family member, etc., and the focus will be on stabilizing the patient. Common or concerning respiratory symptoms include shortness of breath or dyspnea. This may be chronic or acute. For acute situations where dyspnea is sudden, possible causes could be anaphylaxis, pulmonary embolism. Think back to the risk factors for DVTs, clotting, and developing emboli, spontaneous pneumothorax, or possible anxiety or panic attack. Wheezing, indicating possible narrowing or airway restriction, bronchoconstriction, edema, secretions, asthma, or foreign body can be heard as inspiratory or expiratory wheezes. Chest pain, although this can be from cardiac causes or GI causes like gastroesophageal reflux disease and or esophageal spasms, chest pain can also indicate a pulmonary cause such as a PE or a pulmonary embolism. You may have pain with inspiration or expiration. That is why when patients present with chest pain, depending on associated symptoms and history, both cardiac and lung labs and diagnostics are ordered because they both can mimic one another and sometimes are difficult to decipher. Another possibility is musculoskeletal. Causes such as costochondritis or muscle strains. Many times musculoskeletal origins can be reproduced with stretching or may have tenderness with palpation. Different characteristics of coughs can yield very different diagnoses and treatments, so it is so important to be detailed in your cough histories. A cough could be anything from allergies or upper airway respiratory infections, maybe viral or bacterial, to tuberculosis and heart failure. Think about Olcott to help narrow down what we want to know. Is the cough acute, chronic? Is it all day? Is it intermittent? Does it come and go? Is it just at night? What are the characteristics of the sputum, the consistency and quantity? Is the cough accompanied by shortness of breath, night sweats? If complaints of hemoptysis, most of the time this indicates esophageal irritation or possible esophageal varices, but one cannot exclude the possibility of a pulmonary embolus. That is why it's so important to look at the big picture and other associated symptoms. Other important past medical history questions include any prior respiratory problems, history of surgery, biopsy, or chest trauma, history of allergies or asthma, a TB skin test or chest x-ray. Do they have a history of a positive PPD or a history of an abnormal chest x-ray? Do they have a history of a lung function test? When was the lung function test and what were the results? A vaccination history, specifically influenza, Tdap pneumonia, or varicella zoster. The varicella zoster vaccine may be significant because they may have a lesion on the chest wall or side with possible pain and numbness and tingling. Have they had any travel outside the U.S. within the last 6 months? To identify patient risk factors for respiratory illnesses, it is imperative to identify a complete family history. Do any family members or those in close living quarters have a current lung infection or respiratory illness or disease? Family history of lung cancer, asthma, cystic fibrosis, or tobacco use. Thinking about secondhand smoke exposure. Another thing to think about when assessing for a family history of exposures is if the patient has been exposed to any harmful lung irritants, industrial products, or other environmental or work exposures. Question 1 says, dyspnea is a general symptom of several different disease processes. Some factors that may aggravate it are, and it's a choose all that apply question. A, exertion, B, lying down, C, inhaled irritants, or D, sitting up. The answers are A, exertion, B, lying down, C, inhaled irritants. Dyspnea may be aggravated by exertion, lying down, and inhaled irritants. Sitting up typically helps relieve dyspnea. As with all symptoms, the first step of your physical exam is inspection. You will first notice the rate, rhythm, depth, and effort of breathing. Look at your patient's facial expressions. Do they look fearful, panicked? Is there accessory muscle use? How about their level of consciousness? Are they able to sit up? Look at their skin color. Do you see pallor or cyanosis? Do you hear any audible wheezing? Inspect the neck and shape of the chest. It only takes a minute or so to do the inspection. However, if a patient is in respiratory distress, don't even proceed with listening to lung sounds. Call for help and stabilize the patient. Give them oxygen if needed and reposition them while waiting on help. A normal respiratory rate at rest is anywhere from 12 to 20 breaths per minute. Less than 12 is bradypnea and greater than 20 is tachypnea. There are many variabilities in breathing rhythms, but I have personally seen Cheyne-Stokes breathing a number of times. It can be caused by heart failure and consists of periods of hyperventilation and apnea. The picture on the left demonstrates a normal thorax. In a normal thorax, the AP-LA ratio will be 1 to 2, meaning the measurement from the front to back, anterior to posterior, will measure approximately 1 hand, and it will take approximately 2 hands to measure the lateral aspect. We will demonstrate this in lab. The significance is if you have a patient with an AP-LA ratio of 2.2 or 2 to 2, this could mean the patient has a barrel chest like on the right, meaning the patient likely has a history of COPD. When we palpate the chest, we can identify any areas of tenderness, structural abnormalities, check for chest expansion, you'll see this on the next slide, and compare each side for symmetry. On the left, you can see the examiner checking for chest expansion. We will also practice this in lab. With hands placed side by side, you will ask the patient to take a deep breath and will note expansion of the chest. You will be looking for symmetrical movement. This slide gives some great tips for auscultation. I typically start listening to lungs on the anterior side first, right after the heart, and then I move to the back. However, you get to decide how you would like to do this. Make sure you are listening to both the complete inhalation and exhalation prior to moving to the next spot. Make sure to give your patient a breathing break. Do not listen through clothing as this can skew the sounds you hear. You will listen to breath sounds with the diaphragm of your stethoscope. Listen for any adventitious sounds. You will see these on slide 24. You will listen from side to side, comparing each side in a ladder-like fashion. This is the order of auscultation on the anterior side. You will go from side to side, comparing the right to the left. We are always comparing everything in assessment, from lungs to skin to pulses. This is a representation of the posterior auscultation sites. Note the side-to-side ladder-like pattern. You will start near the middle, in between the scapula, and then as you go down, you will fan out to the right and left. This chart is a great representation of the different types of normal sounds and where you will normally hear them. They include vesicular, bronchovesicular, bronchial, and tracheal breath sounds. This is for my visual learners. I really like these images and how they reflect the chart on the last slide, matching the sound with its location. The most common adventitious or abnormal breath sounds are crackles, rails, wheezes, and rhonchi. Make sure you are familiar with these sounds. Crackles and rails are typically seen with pneumonia and heart failure, while wheezes and rhonchi will be heard more with asthma, COPD, and bronchoconstriction. Yes, it is possible to hear all of these sounds. You will document the crackles as fine or coarse, and wheezes can be documented as inspiratory or expiratory. In all adventitious sounds, make sure to document the location and make sure to notify the provider if this is a new finding. You will often hear crackles in the bases. This is because of gravity, and secretions will follow this route, kind of like edema loves lower extremities. You may hear diminished lung sounds and may not be able to hear or hear well, especially in the bases with excess fluid. You will chart diminished in the bases. The left picture is a normal air-filled lung, and the right picture is representative of lobar pneumonia. You can see the opacities or white areas of the X-ray. Notice it is all at the base. Not saying that it can't be higher, but that is the typical presentation. With this, you may hear crackles, or it could be diminished. Also, in the situation of a pneumothorax, breath sounds will likely be diminished or absent because you aren't getting proper airflow and inflation. A pneumothorax, often caused by trauma, is a medical emergency. With a pneumothorax, you wouldn't also have symmetrical chest expansion. The most important information we can share in terms of health promotion are smoking cessation strategies. It is currently the leading cause of preventable disease, disability, and death in the U.S. In addition to the lungs, smoking can affect multiple organs and increases risk of a variety of cancers, eye problems, and inflammatory conditions such as rheumatoid arthritis. This concludes the respiratory lecture. Please let us know if you have any questions.